right, so as we proceed through this case, obviously, so here's our patient. Kind of the big thing here is obviously you see limited right shoulder active range of motion. And really from this we don't really know is, so if you look at it from the side, you can see she has a little bit of a shoulder shrug. And if we go into internal and external torque, so internal torque again is what your muscles are doing, external torque is what gravity is doing. Gravity is trying to, so gravity obviously is coming down over the moment arm, and it's trying to create an extensor moment. So it's trying to like torque and pull. Remember, torque is force over a distance, and so it's trying to pull her down into extension. Therefore, she has to use an internal torque of flexion. So torque coming around this way, it would help go against the external torque of extension due to gravity coming down and trying to push her arm down. So that's the internal torque and the external torque. At what angle of flexion would the external moment arm be the longest? So it'd be probably about where she is here. So she's bending her elbow. She's trying to shorten her moment arm. Remember, moment arm is from where the action, the axis of the motion is happening to the length of the arm. So of course, so her arm anatomically weighs exactly the same no matter which position she's in. But in a position like down here, her external moment arm is from here to draw this up, and it's to right here. So it's at a spot right here. If she goes up a little bit further, so now it's a little bit longer because now her arm is more parallel to the ground. So if her arm is down here, this is the distance of her moment arm, of her external moment arm. And if she could, well, in this arm, her external moment arm is actually shorter than it is here because she's further up against gravity and it's a shorter distance to the axis. But now as she gets further and further up into flexion, she's going to have more and more active insufficiency of her shoulder flexors. So her moment arm was slightly shorter at the very end there than it was initially, or from here, but still not very much. So now the issue, if it's an active contraction problem, is you have a long moment arm. Well, so we don't know. It's limited range of motion. So if she gets up, to here and she can't go any further, like that's no longer a moment arm issue because her moment arm would have been longer and more challenging here than it is here. I'll try to draw this out, but so now you're coming into other issues. You're coming into active insufficiency. You're coming into potentially maybe she has a tight shoulder, and it's this is where the inferior and posterior capsule is getting more taut, and that's why she can't get up in that range of motion. So this will be for a question that's coming a little bit later here. So without moving, changing positions, etc., so she stays in the same exact position, how would you decrease her external moment arm? Well, you simply could just have her bend her elbow. So you can see that she's trying to do that. But if she bent her elbow and brought her elbow to 90 degrees, now her moment arm is shorter. This could be one thing that you could do to see if it's an active contractile tissue problem or a passive contractile tissue problem. Because if she bends her elbow and she can't increase her range of motion actively, then I'm starting to think, well, one of two things. The shoulder flexors are really weak and they're getting really actively insufficient, which I would be less inclined to think because she passed through the long moment arm. So then with the elbow bent, shorter moment arm, I would start to think about more of a passive non-contractile tissue issue, lack of normal orthokinematics and so forth. So that's what I would be thinking as we started differentially diagnose. So now we'll kind of already done a little bit of clinical reasoning and we'll just get a little bit more into it here. So what could be the reasons? Well, obviously we kind of talked about them, and so it could be an active contractile contractile problem of the shoulder flexors and or rotator cuff as stabilizers. Remember, you have to have the rotator cuff stabilize the shoulder, the humeral head in the cup, so that you can go up against range of motion. It could be a non-contractile problem, so it could be a tight posterior capsule, inferior capsule, type of a limited type of it. It could be neurogenic. Again, just not knowing anything, it could be essentially is it an active movement problem, so contractile tissue neurogenic type of a problem, or is it a passive non-contractile tissue, which would be like the capsule or soft tissue structures or whatever. So she goes to the range of motion. So how would you test these different hypotheses? Well, this is why you would do active range of motion, passive range of motion, and accessories, and do a good neurological exam. So again, in number 3, you would have done a normal neurological exam. In number 4, you do active, passive, and accessories. And so she gets to here, and let's say, so she's there, and I passively take her, and she gets, and let's say this is her normal range of motion. Well, let's just go as far as she can here. So this is her normal active range of motion on the other side, and this is where she stops. If I take her arm passively and bring it up to here, I'm very suspicious of an active contractile type of a issue. And then, of course, I could always do accessories to see, because if it was a non-contractile tissue, passive range of motion would hardly improve at all, if at all, and then you would have accessory joint play would be restricted as well. So those would be things that you would want to do to help with your hypothesis. And then neurogenic would be, a neurological exam and or medical exam if something else. So typically, this is a hypothetical deductive reasoning. You have a hypothesis, you are testing the hypotheses, and then you are going to help rule in or out one of those things that I discussed. If you remember, heuristic reasoning is jumping to a conclusion. Essentially, it's pattern recognition. So let's say you work in a clinic that sees 90% post-rotator cuff repairs, and you see this, you're going to jump to the conclusion, okay, well, let's say rotator cuff repair weakness, that she's not getting full range of motion. But if you work in a clinic that you see hypomobile shoulders, so like frozen shoulders, you're probably going to look towards that. This is why hypothetical deductive is better, because you can jump to conclusions, and heuristic reasoning is fraught with issues. So her onset had a rotator cuff repair. She's 14 weeks post-op, small rotator cuff of the supraspinatus only. So remember, with you can have multi-tendon tears. So supraspinatus is most likely to tear. Sometimes you can have supraspinatus, infraspinatus, and teres minor. And sometimes you can have subscapularis. That's typically more isolated by itself. If you remember the value of different rotator cuff tear tests, it's better for subscapularis. So if you remember the belly press test, if you remember the bear hug test, if you remember the liftoff test, those all have much higher value diagnostically. But again, subscapularis tears are more rare than supraspinatus and infraspinatus and teres minor, which typically are like drop arm, horn blowers, like all these different modified versions of manual muscle test. So she's coming to you from a surgeon who is unhappy with her previous results, or previous rehab. So did somebody mess up? So 14 weeks post-op, small rotator cuff repair, and she's coming in and this is her motion after 14 weeks of a small rotator cuff. So do you believe the surgeon is justified in his or her concern regarding the patient's progress? And so why or why not? I absolutely think this surgeon is justified. She should have full active range of motion by this time with a small rotator cuff repair. And so yeah, I don't know if there's much else to say on that one. So by 14 weeks, they should have full range of motion. And you can see that she obviously does not. She has a shoulder shrug, and so probably true isolated glenohumeral motion is even less than that. What is that? 105, 110, something like there. So you do your exam. You determine she has normal arthrokinematics, so normal joint play. Question is, should you have assessed this? And then yes, you could. just remember, I think the thing, what I was trying to get at there is, should you do an inferior glide? So should I bring her up and do an inferior glide? And typically, if you bring them up further into, if studies are showing, if you leave them down at their arm down at their side, and just do a longitudinal distraction, that will pull on the supraspinatus. Because remember, supraspinatus runs across here and attaches here. But if I bring it up into a, kind of the resting position, about 55 degrees of abduction, and kind of bring her up in here, it's on slack. And so you could check that. And especially at 14 weeks, she's not fully healed and repaired, but like especially if you do it at end range there, the supraspinatus is on a lot of slack. But of course, you'd want to get that from your surgeon if they're okay with that. What would your treatment strategy be from here on? What would the next 2 to 3 week time frame? And so just kind of, what would you do in this case? And I forget what else I have on here. So get to the point, and essentially you have an active contractile tissue issue. You have a little bit of shoulder shrug. You don't have a so you have normal arthrokinematics, you have normal scapular movement, you have strength issue and endurance issue. And I would do a lot of short lever. So I would have her maybe sit, put her elbow up on here, bend her elbow, and having her try to work in through the range of motion, have her do some active assist, standing cane exercises, having her do pulley exercises with active assistive range of motion. And maybe you have to work, shorten the lever arm. So you could do those things where she's standing, holding and facing a pulley, pulling down, and just so actively raising this arm up as far as you can get. And once she gets to there, then she kind of pulls down just a little bit, just to kind of get her past the hump with the other arm, and or shorten the lever arm. And then doing, reaching overhead type things with maybe the elbow bent. Essentially just progressive short range isotonics and or isometrics or multiple angle isometrics in the position that she's having trouble with. If this was where she stopped, I would probably bring her down just a little bit. And so if this is where she stopped, have her start from here, in this position here, and have her go up to that position. And then have her work through that short arc range of motion, and then just bringing it back down. And then to have her bend her elbow as much as she can to be successful and give her some small wins. And so progressive strengthening, working on posterior rotator cuff, you still can do, rows, and pull, scapular retraction, shoulder depression, all those kinds of scapular strengthening types of things that stabilize the scapula a little bit. But you're going to have to work into the range a little bit that she can tolerate, and then just progress her accordingly. And I think the last one is just kind of a challenge. So let's say it comes from a friend, and what kind of mentorship? So hopefully, good mentorship in the sense of, hopefully the friend reaches out to you and you just kind of discuss and say, hey, from my exam, what I picked up here is it seemed to be an active strengthening issue, and so we're going to try some short arc range of motion. We're going to try some of the things that we just talked about there. So hopefully you found this helpful, and if feel free to reach out or put on the discussion board, and then see if you have any concerns. All right, everybody, take care.